conducted by Palliative India. All of you might have known us through the foundation course, and now we are moving a step forward. We are trying to enable you how to teach what you thought here. So without much delay, I hand over it to Dr. Sridevi to give a brief overall view about the program and then the faculty introduction for the session facilitation. Ma'am, over to you.
Thank you everyone for joining us after you have done your foundation course. I understand most of you were with us for the 20 sessions, which is the foundation course in palliative care. And thank you so much for your interest in, this really shows the interest in starting to teach palliative care to your medical students. That is a great pleasure to know. And as we have circulated the schedule, we have 5 days together. And after the first 2 days, all of the sessions will be mostly in small groups. So you have to be really present here. You know your group. We have introduced each other in the group, which group you are and which institution you are from. So meet your group members during the first 2 days so that you can be familiar with them. There will be a lot of group work. We'll be sending you materials beforehand. We'll be giving you materials through which you can go through. And next day, we'll be having discussions based on the materials shared. So it's basically a flipped classroom method in the last 3 days. So we expect you to be with the session so that your group members will benefit by your inputs. Thank you so much once again. And we will move on to the session. The first day today, we have Dr. Rajagopal taking us through the vision, why we are doing this program, why we are gathering here together, what is the vision behind it, and the purpose behind the whole training program. Dr. Rajagopal is a chairman emeritus of Pallium India and director of Trivandrum Institute of Palliative Sciences. I am sure you might have had one session from him in one of the foundation courses. So I'm not reading everything written on the slide, but he's a great teacher, and it will be good to hear from him directly why Pallium India is taking up this program, and you all are here with us for this program. Thank you everyone once again, and over to you, sir. Sir, you are muted, sir.
As usual. Sri and Sri, thank you very much for the introduction. I see that 24 people have logged in, but as far as I can see, only 4 people are really present for me. Nandini, Raksha, Veena, and Swati. Thank you. Okay. Rama, good to see you, Rama. Of course, at least in virtually, let us meet up once in a way.
Thank you, sir.
No, I didn't want to trouble you, especially apologies to those who have forgot or did not get the time to apply makeup. But
they're post-operative only, sir.
See, virtual education is by no means anywhere near what education should be. When the human interaction happens, that matters a lot. And it is rather depressing to talk to many black screens. So Dr. Narayana, Dr. Amarnath, Banu, Darshana, Sri Priya, Premnath, Anupama, Varalashmi, Anu, and a couple of nameless windows, Shweta. If at all possible, please switch on your video so that we can at least talk person to person. Because I have a personal request to make to you. Very personal. I hope Sri and Sri will not be annoyed with me for making use of this opportunity for very personal matters. But I want your help as your future patients. I don't know which one of you is going to treat me. I have only, as Sridevi has heard from me about 73 times, I have only 10 to 15% chance of dying a sudden death. At my age, I have at least 10% of chance of getting cancer and dying of it. I have at least 7% chance of dying with dementia. This is real. This is why I think I want to talk to you person to person. I need you. But it is not only I that need it. It is not only those nameless patients. It is our own family members. And you may not be around for them when the need arises. Unless you together have changed the mindset of the medical professionals. That's the task you have, you see. It's not a small thing. You have the duty and responsibility to improve the mindset of professionals all over the country so that people like me can get some justice, some fair treatment, some compassion, and a peaceful ending also when the time comes. How many years has this been going on? Does everybody know who founded palliative care in India? The founder, Dr. Lucito D'Souza, the oncosurgeon from Mumbai, built the first hospice in Mumbai, Shanti Avedana Southern, in 1985 or 86, I'm not sure. So you see, it has been more than 35 years. A lot has happened. The ground is laid. Now, in a path through which Dr. D'Souza and many pioneers walked through very uncomfortable paths, treading thorns and stones. Now, at least some path is laid. I'll explain why I say that the path is laid. And you, as medical teachers, have the opportunity to instill some humanity into the mindless, totally technical, body-oriented, not person-oriented, body-oriented healthcare that is given out. I don't know if you have heard either from me or somebody else a quote from Dr. Eric Castle. Eric Castle said, "It is persons that suffer, not bodies." I'll repeat that. It is persons that suffer, not bodies. And all our medical education and all your medical education that you have been imparting to your healthcare students, unfortunately, so far have been mostly on the body, on organs, on microorganisms, on tumor cells, very little on human beings. And this is something that Providence has given you the opportunity to do now, to bring humanity into medical practice. So let me talk about the current status, why I am scared as a patient tomorrow. By the way, between us, now that we are all friends, I'm not afraid of death, but I'm afraid of dying. I'm afraid of dying because of the suffering. And unfortunately, that suffering is very much a reality for the vast majority of people in India. Let me share my screen and also share some thoughts with you. 1 second. Initially, I'll be painting the dark picture of what is happening to people with serious illnesses today. and what you will be doing. Today, you may be overwhelmed. You may be wondering, look, the whole healthcare world in the country is in darkness. What can I do as a one person? And I'll very confidently tell you, what we have learned is that if you light one lamp, not only it destroys the darkness around it, but many lamps will be lit from it. It matters. Everything that you do matters not only for me as your patient tomorrow, but for all the 7 to 10 millions in serious health-related suffering in the country. The 7 million is the estimate of the Lancet Commission based on 20 different treatment 20 health conditions. There are many others that cause suffering. The total number is likely to be closer to 10 million. And only less than 4% of them get at least basic pain relief, leave alone all aspects of healthcare. That's a sad state of affairs, which you are going to change. The third row, Western European figure, shows how much the per capita morphine consumption should be if the majority of people in pain have access to pain relief, 150 to 250 milligram per capita. And you can see the first row, India. Where does it come? About 1 in 1,500? That's how bad it is. Kerala is doing a lot better, about 10 times much. But that's not really something to boast about. It is still about 1 in 150 of what it should be. And remember, this global average, the last row. The last row is of all countries where this data is available, which is more than 150, including main countries with hardly any use. And even then, the average is 6.3. And see where we are, even in Kerala, Sridevi, where we boast of having more palliative care and a beacon and all that. It's nice when people say that. We are still here. And the national average is here. Who is going to change it? You are. You all have been given this opportunity. The darkness is an opportunity for you to shed some light. Sanghamitra is a person whom I admire a lot. And he, the oncologist, came out with this sentence: the poor die in misery of neglect, the middle class die in misery in ignorance, the rich die in misery on ventilators, and no one gets a pain-free and dignified death. And unfortunately, because I have some money in my pocket, I am at graver risk than the majority of Indians. Oh, now even the low, even poor people are at risk of my misery being accentuated on ventilators. Some of you are intensivists, some of you are anesthetists, Rama and I are anesthetists. And we are used to seeing people on ventilators. Till the 1990s, any intensive care was only for salvageable situations. In the 90s, the situation changed, and by the turn of the century, around 2020 or so, the picture completely shifted. And here started the Indian disease. Don't think that this is global. Don't think that this is what you will see if you go to UK or USA. The Indian disease of intensive care syndrome happened, so that now intensive care is not only for people with salvageable conditions, it's for anyone dying. The distinction is very obvious. Sri Priya will be sending you this presentation to everyone. My apologies to many of you. I may have talked about it during your foundation course or some other course. Apologies for the repetition, but then I'll be going through it in faster today, just as a sort of review. Please note, this is 2019 publication, and this is 2020 publication. In Europe, Western European countries, which are supposed to have the most optimal end-of-life care, unlike USA, there 90% of people are taken off artificial life support systems when the specialist doctors have agreed that the condition is likely to be incurable, unsalvageable, that the condition of the patient is unlikely to come back to reasonable quality of life. Now, the horror in India is that such withdrawal of artificial life support happens only 30%. 70% of people are continued on life support systems till they eventually die, which means the misery of my suffering on a ventilator with all those tubes, suction, which is supposed to be the most horrendous human experience possible, they are going to happen to me for weeks together before I'll be allowed to die. And not only that, the 30% who are actually withdrawn from the ventilator go through huge suffering. They are not given palliative care. Today I got an email from a medical student in New York. And he writes about 3 months back, his grandfather died. He talks about the misery. He talks about how he pleaded with the doctors to give him a tiny dose of morphine, because when the artificial life support was withdrawn, he was in agony. It was denied. Nothing was given to him. He saw his grandfather suffering and dying. And this is the sad situation that you have to change. All this happens despite Indian recommendations like National Cancer Grid, Association of all cancer hospitals in the country, or most cancer hospitals in the country. They say don't do it. But the same people who participated in the workshop and created the guideline often continue to do it because they don't know how to make that change, how to transition, how to overcome the resistance, how to talk to families. And teaching the medical students and changing it for the future is a privilege that you all have. And also to minimize the current cruelty of catastrophic health expenditure. And I would like your medical students during their course, which will start from their foundation course before MBBS starts, to the internship, I would like you to remind them of the duty of the healthcare provider as defined in India, 2018 publication, is to mitigate suffering. It is to cure sometimes, relieve often, and to comfort always. There exists no exception to this rule. Please help your undergraduate trainees or postgraduate trainees to understand the palliative approach that all clinicians should adopt. Okay, I think several of you are from Puducherry, and one doctor from Puducherry told me the one difference that palliative care training, or the one big difference that palliative care training did to me was that I learned to sit down. I learned to sit down beside the patient even if I am busy, even if I have only 1 minute. Because by sitting down beside them, you are conveying to me that my time is for you. You're not standing and looking at the screens and looking at the case sheet and looking at the MRI scan and about what's happening outside. Eye contact at the same level. I hope, in addition to all your classroom sessions that you will be doing, you will be able to show it to the people that you are going to look after. I know very often there will be no chair beside the patient. Even if there is a stool there, on top of it there will be a flask, a spittoon, and so many things. But these things can be changed. And that will be one major difference that you will make. So what I'm saying is, over the next several sessions, Sridevi's program will convey to you many aspects of healthcare that are already in the curriculum and which you can learn to teach them. But I hope each one of you will be the role model that they will follow. Because when they see you sitting down and holding your hands with compassion in your eye, I know everybody will not be moved. That is too much to expect. But in every group, there will be a few people who will see what you are doing, who will see the change that occurs in the patient's face with your touch. And they will be changed. What am I saying? The course will happen now. The mode of, many methods of assistance in the teaching process, with the Word documents, PowerPoints, videos, and how it could be incorporated into different modules in different parts of the course, all that will come to you. But please remember that your role is much more than that. Your role is to demonstrate humanity in healthcare to your trainees. To your trainees, so that even if you are not treating me, even if it is somebody else in another town, those medical students will learn a little bit of compassion in action from you. I understand that Dr. Kadambari will be talking to us soon about integration of palliative care into healthcare systems. I believe that would be one of the most important lessons to be learned. Thank you, Dr. Kadambari. The recommendation is that palliative care should be integrated into healthcare at all levels, primary, secondary, and tertiary levels of care, across the continuum of care. That's from the beginning of the suffering to the end. That means, in addition to teaching undergraduate students who are easier to teach, we must also engage our colleagues, specialist doctors who are full of knowledge, so full of knowledge that they will have a harder time to unlearn what they have learned and to learn new things. They will have to unlearn the habit of standing up and looking down and talking and sitting down. They will have to learn the new art, instead of being impersonal and stiff, of having compassion in the eyes, being able to see suffering, and being able to recognize that we have a duty to do something about that suffering. Please remember, I will not talk about anything more about integration now because it's going to come from Dr. Kadambari. But it is impossible for palliative care units to give the bulk of healthcare, bulk of palliative care. The reference to palliative care units anywhere will happen only in severe suffering, only towards the end. The bulk of healthcare will have to happen at the hands of every clinician, every nurse, every doctor, every physiotherapist, Everybody learning how to interact with patients, how to interact with patients with compassion. And Sri Priyanka shared with me your profile, but I have forgotten. Are there many people from community medicine here? Because if you are here, you have a particularly important role.
Yes, sir.
Because
I am Dr. Narayan from community medicine, sir. I'm a
Dr.
professor of community medicine.
Dr. Narayan, what
Yes,
a
sir.
privilege to have a professor himself in our group. Thank you for being here. But because you are a professor and a senior person, that is a greater opportunity to influence the rest of the public health community in the country. Because you, instead of so many other people here who will be working only in hospitals, you have the privilege of reaching out into the community. Because unless the community is involved, this integration is almost impossible. Because the person who doesn't have food to eat, the person who doesn't have, it actually happens. People saying, no, I don't need medicine 3 times a day after food. Give me only twice because I get only 2 meals a day, or sometimes only 1. All those problems can be solved only at the community. So thank you, Dr. Narayana, for being here.
Thank you, sir.
And I hope the growth of palliative care in community medicine as a discipline will grow so much that we will demonstrate it in the field, not only in air-conditioned hospitals.
Thank you, sir.
Thank you, Doctor. So, I am skipping through the rest of what I had prepared on integration because this other session is going to happen. Please see, when I said earlier, I have been moaning about problems, right? All this time. This is not happening. That is bad. This is a problem because I'm scared, you see, about my situation tomorrow. But let us look at the positives. So many good things last 10 years. India now has a national program for palliative care. It has been not very successful, but it's becoming more successful now. The laws governing opioids have been amended in 2014, but not implemented in many states. Our facilitation team is working with individual state governments and national health missions to make it possible, but it has not happened all over the country. But please remember, any one of you who does not have access to morphine in your institution now, please connect with Sri Priya and inform it so that Sri Priya can get you in touch with the facilitation team. The rules are so simplified that any healthcare institution can now have access to oral morphine, provided they are able to work with the drug controller, who may not understand all the things. They may not know what is really the current rule. It may be necessary to work with them patiently, but it is possible. And friends, one of the best things that happened in this country is that the National Health Policy of 2017 includes palliative care. Well, policy also needs to be translated to reality. But Sridevi will be able to tell you later how much of work we put in during the COVID years to work with the National Health System Resource Center to create all the teaching modules, train national level trainers, then to train state level trainers from every state. So significant work has happened already, and I'm sure more will happen. But now what concerns us are what are there in the lower 2 boxes. MBBS and BSc nursing curricula now have palliative care. I know that this group is all doctors. But as your work moves forward, I hope you will work with the nursing college attached to your own institution. Because we are more or less powerless unless our nursing colleagues work with the patient, because very often you may be there for half an hour with the patient or less in a day. They are there for 24 hours. We need to engage with them. Sorry. But for now, our most important task is to understand where we are with the MBBS curriculum. And get it organized, work with your institution. See, every one of us is only one single human being. But with our colleagues, we will gain a lot of strength. And especially because some of you are very senior, like Dr. Narayan, you will be able to make a change. The current revised curriculum, which is operative from 2019, has 20 modules under 12 teams related to palliative care. They are distributed from the foundation course before when MBBS starts to internship under various departments. Today, the curriculum includes pain management, end-of-life care, and 8COM. 8COM is attitude, ethics, and communication. But if when you go to, with all your good intentions and try to address this, when Dr. Shivaranjani and Dr. Shweta go with all your modules, somebody may ask, hey, there is no time for symptom management. We have time only for pain management and end-of-life care and 8COM. But then, how can you give proper end-of-life care without symptom management? End-of-life care is included, and that is the opportunity for us to bring in all symptom management into it. So look at the second panel, pain management, end-of-life care, and 8COM are the major components of the palliative care part of the new curriculum. It is to be taught by various subjects. So when all the pain management gets done by anesthesia, or all the analgesics are taught by pharmacology, you may feel powerless unless you are able to work with your institution and create a system. So I hope you will take it as your mission, not only to teach palliative care, but also to ensure its palliative care education being rationally in your institution's teaching program. Oh, Dr. Two professors of community medicine. Sairu, I saw you only now. So,
good evening, sir.
Good evening, Sairu. I would like you to take part in this poll. Sripriya, are you ready with it?
Yes, sir.
The question is, I just now talked about the 20 modules to be taught under 12 themes according to the curriculum, which should have been in place from 2019 batch, which in most institutions may not have happened even now. So, but at least now, better late than never, let us try to change it. In this education, my question is, in your own institution, so this is confidential. We don't identify the people who take part in the poll. We only want to get a general picture. What happens? Does it get? Do you think it happens in your institution? If so, is it less than a quarter or less than half, or is most of it being taught? Sripriya, does everybody know what to do for participating in the poll?
Yes, sir. We have got till 25 responses till now, sir.
But you have
26.
36 people, right?
Yes, sir. Out of that, I think 4 or 5 are us only. So 30 have responded now.
Very good. Only 6 not us. This is a bit like the exit poll after every election, you see. Initially, I was feeling, oh, this is fantastic. Half of them have most of it. There was 3 out of 6. But as more votes started being counted, it has come to 20%. But friends, personally, I think it's good news. It's good news if at least 20% of institutions among those who are participating here have most palliative care being taught to undergraduate students. That's phenomenal, fantastic. Everybody who has been working towards this, congratulations. But unfortunately, the majority is yet to be done. So, friends, how much time will Sripriya give me? Sripriya has given me more time. Now I have at least another 9 minutes more. With that, would you like to tell me, what do you think are the major stumbling blocks to incorporation of proper palliative care education in your institution? Is it lack of faculty? Is it lack of a palliative care service in your institution? Because if you do not have a palliative care service, whatever you teach will only be a bookish teaching. Sripriya, if you will close the poll with the sad understanding that only 20% have most of palliative care being taught to undergraduate students, which also can be taken as good news. But what do you think are the major stumbling blocks? I'll come back to the presentation in a little while. What are the major blocks that we will have to overcome? This I am asking you so that together we'll be able to find some solutions. I thought Ashwati was beginning to talk to me, then I found that she is talking on the phone. Sorry, who is?
Sairo, sir.
Sairo.
I think in my institution, actually what is happening, the CBM each year it is changing its, changing so many things. So every in that rush to stabilize the curriculum, maybe we are missing out on teaching most of it, but step by step, I am optimistic that we can hike the teaching through an integrated module or something like that. Sir. One thing is every batch has got slightly different recommendations.
Sir, you are muted, sir.
Sorry. New thing. It's a new thing, and in India, things change slowly. It has been only 4 years or less than 4 years. So that is understandable. But one thing that Cyrus said is that in the process of that changes, this does not really possibly attract enough attention because it's specifically because it's new. And Sairu comes from one of the tiny minority of colleges in the country where there is a good palliative care unit. The other day, somebody was telling me among the 42 or so medical colleges in the country, only 2 have good palliative care service within the institution. And one of them is Cyrus Kottayam Medical College. So these are problems to be taken care of. And several people, Ashwati, Madhu, Nandini, Harini, Swadi, Veena, Rama, Priya. Oh my God. This is, Dr. Narayana said it is lack of trained faculty. Everybody else said there is no palliative care service. I think that, so Harini, Shweta, what are you going to do about it? You, I'm not going to ask what is the principal or dean of the college going to do it. What are you going to do about it? Can you see it as an opportunity to get something started? Being the founder of that movement, the founder of infusion of compassion into healthcare as a whole in your institution. I hope the majority of you who said the lack of palliative care services is a problem will try to create one. I mean, Sridevi is here and we'll work with you for further education of your faculty and other staff. In Kerala, there's a government order which is no, I mean, there's no budget allocation yet, but it will happen that all medical colleges must start it within the year. So some things will move, but in the rest of the country, it may not happen so easily. And unless you light that lamp, remember what the tiny dragon said, I showed you the first picture. Unless you light the lamp, no one else might. So before the course is over, Sri, I hope there will be some discussion about this, about what everyone can do, not only to teach palliative care, but to initiate palliative care services. Dr. Narayan also said lack of trained faculty to teach. That's a big problem. Because even if the curriculum is there, if an untrained palliative care naive person goes, the faculty member goes there and teaches, one, the heart of it will not be there. Secondly, see, I don't know about the current status. That textbook of pharmacology is Satoshkar. I haven't seen the latest edition, but I know that till recently, the things that strike out under the title of morphine is respiratory depression and addiction. They are not talking about in what conditions that happen. It's presented as if that is the universal. So there are challenges. But Dr. Narayana, I don't know, you are a medical teacher and a head department and a professor, so you know better. In our whole medical council's regulations, which also is followed by National Medical Commission, colleges can have guest faculty coming in, both to get an service initiated and to come and help in teaching a palliative care to your students. It is technically possible to bring in guest faculty. I don't know if that's helpful. In the whole town, if there is nobody, that may be difficult. It may not be sustainable. I know there are challenges, but who knows? That might be one of the solutions. My time is almost up. Thank you for offering your comments. This is one of the feedbacks that we got from my previous course. This new pattern of curriculum is so hard to understand. I couldn't get head or tail of it. Thanks to Valium team for Hey, Sridevi, compliment to you. Sri Priya. Thanks to Valium team for simplifying it and help to understand various modules. Most of all for the extensive and valuable resources. I'm preening a little bit and feeling proud of our team who made this kind of feedback possible. But let us also understand that this is only a beginning. This training can only do a bit of work unless it is continued support for everybody who wants to develop it. One course alone may change very little. So I'll remind you, please light that lamp. We'll work with you. Thank you very much.
So we can have 2 minutes to take a few questions. Do you have any?
Very good. Sri, please lead the discussion.
So I am, first of all, I'm glad that you recognize the importance of having palliative care services within your institution. And as Sir mentioned, we have facilitators working in each state. They'll be in touch with you after the program to help you to start some kind of palliative care services in your institution. As you only rightly pointed out, without services being offered, it might be difficult to demonstrate such model to students. So please allow us to work with you so that we can take some initial steps towards palliative care service. If you have any questions before winding up Sir's session, you can ask some questions, either unmute or you can type it in the chat. Can't see any questions, sir. Dr. Madhu, you wanted to say something? Okay, so thank you so much, sir, for today's session and just sharing whatever we had in our mind with all the participants here. I'm so glad to know that everyone understands the importance of this specialty as well as the training program in their own institution. Thank you so much, sir.
Sri Devi, did you notice that we have the some sort of a record? You have the youngest participants at the Global Fellowship Program today. Hardly visible behind Neelakshi, there is a young participant. See,
yes,
the
sir,
head
that's my
peeping out.
daughter.
Hello. Little Neelakshi, hello.
Hello, Kwa. Yes, sir.
Oh, I said Global Fellowship, no, Faculty Development Program. Sorry, I made a mistake. Okay, thank you, everybody.
Thank you so much, sir. So all the participants, next session will be on principles of integration. So I think you all will be familiar with the term than us about horizontal integration, vertical integration, and you might have gone through several training programs to understand the concept of integration, how it works, I'm sure. But today we will be talking a little bit deeper into the concepts and philosophy of integration. Today our faculty was Dr. Kadambari from JIPMER. Unfortunately, some last minute emergency happened and she is unable to join us, but we have her recording with us. So we'll be here to answer some of the questions and we'll be going through the recording right now. She was all prepared. She used to take this session for all the batches. She was very passionate about this topic specifically. She works with the medical education unit. She is also heading the surgical oncology department with special focus to treatment of breast cancer. And she is working with medical education unit for quite some years. So we'll move on to the session on principles of integration, and we'll take up questions in between and towards the end of the session.
Involved in undergraduate education for more than 25 years now. And I have been associated with the medical education unit of JIPMER since 2006. Okay. So we'll begin with what is integration, right? Integration basically means putting together many parts so that you get a whole. But as we all know, the whole is more than just the sum of the parts. It's not just to bring a more familiar concept. bringing in anatomy, surgery, physiology, medicine. These are the parts, and putting it together and trying to understand the practice of medicine. So the practice of medicine is much bigger than simply knowing anatomy, physiology, and other subjects. So that is what is integration. And that is something that we expect to happen during our undergraduate training program. So if you look at the day, a day in the life of a doctor, there are so many activities and so many expectations from a doctor, from diagnosing, prescribing, and offering treatment, and also to stay current with knowledge and technology, etc., and also to have the service orientation. So there are different aspects to a doctor's practice, which we have to put together and integrate. So our life itself as a doctor is one huge effort at integration. So it wouldn't be wrong to say that it is a core aspect of medical practice itself. So as teachers, when we talk about integration, what do we need to think about? One is we need to understand what it is and how actually it occurs. And the second question is, as teachers, what are the ways in which we can ensure or we can help this process of integration to take place? Yes, merged into one another so that the parts are no longer seen. Okay, right, thank you. So in terms of learning or in terms of education, integration refers to knowledge synthesis. That is synthesizing different sources of knowledge and developing your own knowledge. So that means the student or the learner is able to make connections in order to develop new knowledge. So essentially, integration is happening in the mind of the learner. Okay, that's the first thing that we need to understand. So it has to, whatever you do, whatever efforts you make, ultimately integration has to happen in the mind of the learner. So if you take our MBBS students, there are so many subjects that they have to study about, and each of them are heavy and taxing with in terms of the vastness of the content. So it is the student has to, as they go through the course, they have to make all the connections between these various subjects so that they can traverse the complex path of medical practice. So this is where integration is important in undergraduate medical education. So basically, they are trying to connect and correlate knowledge from different sources, basic science, clinical, etc. And therefore, and by making these connections and developing new knowledge, they are able to understand what is required of them to practice medicine as a professional. So these are three ways in which I would say integration can be looked at. One, it is an educational outcome, which is integration of learning, which is what we are trying to aim at. Two, it can be looked at as a learning process. That is where knowledge and memory, like I mentioned earlier, integration happens in the mind of the learner. So it is a learning process. It's a mental process which is happening in the mind of the learner. And the third aspect of integration is what are the educational practices which are required to achieve this outcome, which is integration of learning. And one of them is curriculum integration. So if you look at integration as a learning outcome or integration of learning, it refers to a higher order learning. So the student moves from understanding basic concepts to more abstract conceptualizations. That is what, going back to the first point, that putting together information from different subjects and coming up with how to practice medicine. So that's a more abstract concept. It is how the student learns the different subjects and makes the connections and finally develops a practice of medicine. So isolated facts are put together and they find newer and different ways of using that knowledge. Why is this important? Because we want students to have a meaningful learning. And this happens only if current knowledge is used to be built upon by adding new information. So new information is in a way integrated with current knowledge to make learning more meaningful. And to develop a domain of knowledge, a vast knowledge base, if they are not able to make these connections, whether it is current knowledge with new knowledge or knowledge from different sources, knowledge gained at different times. So knowledge gained in the first phase with knowledge gained in the third phase of the curriculum, knowledge learned in different places, knowledge gained in the classroom, in the bedside, in the community. There are so many areas where knowledge is gained. So they have to put together all this knowledge in order to build a domain of knowledge. This is where this integration is important. The second way of looking at integration is what I said as a mental process, right? So this process of integration is happening in the mind of a learner, and where they are able to put all these different information sources, they are able to not only identify but they are also able to establish the relationships, and therefore they expand their knowledge base. So for example, undergraduate education, making connections within different, say, if you take physiology, making connection between the physiology of the nervous system with physiology of the cardiovascular system and so on, or between various subject domains, making connections between anatomy and physiology, anatomy and surgery, and physiology and medicine, and so on. So this is knowledge integration, and that's what we expect to happen in undergraduate education. So integration is not something which is a new thing or to be learned as a new technique. It is natural to us as thinking individuals, and it starts very early in childhood. Children as young as 4 to 6 years are known to add on new knowledge to what they have already been exposed to, right? So it is a naturally occurring process to build on pre-existing knowledge. And it starts as early as the age of 4. And by the age of 6, as the child gets used to this process, they become more and more independent. They have faster processing speeds. They have a wider knowledge base. So they need very little support from the teacher or the external environment to process this information and to integrate it. So what we need to do as teachers is just to build on this naturally occurring process and to facilitate it, right? So therefore, the core aspect of integration is to have a knowledge base, right? So unless there is a knowledge base, they will not be able to make these connections. And fundamental to building the knowledge base is building memory. And this integration should happen at the memory level itself. So before we go into what is memory integration, I'll quickly digress here to revise with you. I'm sure all of you must be knowing this already. Just quickly to revise how learning actually occurs in any experience in life, right? So as human beings, we go through several experiences. I'm not talking about simply our experiences in school or college or academic experiences. It's life in general. And all these experiences are, you can say they are stored, or they are, I won't use the word stored, they are assimilated in different areas of the brain. And these are called representations in various locations in the brain. And this process of where these experiences are located in the brain, that is called encoding. Now, when these representations are solidified or made more concrete during the act of sleeping, right? And this entire process, this entire process is called, it leads to the storage of information. Now, it is not necessary if information is simply stored, right? It will get lost out. All of you must have heard of short-term and long-term memory. So how it gets encoded in long-term memory is storage and retrieval are required for knowledge, for learning to actually occur. And this is simple. It's simple education 101, you can call it. We teach them, we help them to build the knowledge, and then we test them in order to retrieve whatever learning has happened so that it gets more concretely ingrained in their memory. So for this kind of integration of memory to happen, reactivation of prior knowledge is when they are learning new information is being shown to result in a stronger association. So obviously the applied aspect of this statement is that when you ask a question in surgery, for example, I'm a surgeon. So when I ask them a question in surgery in the exam, if I ask them a question in a portion of it in anatomy, they are able to make better association between surgery and anatomy. Happens with all the other subjects as well, right? Because actively reactivating by constantly retrieving the information, previously learned information, it builds a stronger memory base. Now, coming to a very primarily, a very basic question. Why is integration needed? Would anybody like to better outcome? Okay, I would take that as a learning outcome. Yes, better understanding.
Yeah, good afternoon, ma'am. Departments.
Our CBME curriculum. Right. So to answer this question, I will go to just now, Dr. Vandana mentioned integrating basic and clinical sciences, right? All of us are, I don't think any of us disagree that this is an important aspect of undergraduate training. So why do we need this? Because we want them to understand clinical science and symptoms. We want them to relate clinical features to mechanisms of disease. We want them to develop diagnostic reasoning and to solve difficult diagnostic problems. So by recollecting their basic anatomy, physiology, etc., they are able to solve a diagnostic problem, right? So I'll give you a quick question here. I'm not sure how many of you are clinicians. I'm sure most of you are. Do you, in your routine practice, use your knowledge of basic science in your routine practice? Okay, in your day-to-day practice, do you use your knowledge of basic science to make a diagnosis? Can you answer in the chat box? Their knowledge of anatomy and physiology to make a diagnosis. Okay, when they're auscultating the lung, they say, okay, in this area, it would be the lower lobe, in this area, it's the apex. So that they are trying to, but when we do it as clinicians and as experienced clinicians, we don't always consciously add that element of our knowledge of basic sciences. It is already there in our mind. And this is the process which is known as encapsulation, right? It's already there. We don't go step by step. We jump a few steps. And the second thing in experienced clinicians is the formation of what are known as illness scripts, okay? So illness scripts is, as I have seen patients over the last 30 years of my practice, I have seen similar patients with slight differences in the way they present. So I have a script in my mind of what, for example, a breast cancer would look like, would present with, or what would be the clinical features, what will be the examination. So I will have a script. So when I'm seeing a patient, I don't need to take 45 minutes to actually make a diagnosis because I already have that script in my mind. So these things happen as we become more and more experienced in our clinical practice. But there is an exception. If I face a difficult situation, if I face a diagnostic dilemma, then I will go back to my knowledge of basic sciences in order to explain what is happening and to make a reasonably correct diagnosis, right? So we do need basic sciences. The way we use it differs according to our level of experience. Okay, so therefore, in undergraduate training, it will help students to deal with complex problems. It will foster higher order thinking. You must be familiar with this term. Vertical integration, as you have rightly mentioned, addresses problems which are real world. That is, clinicians can share their experiences and the student is able to understand, okay, this a point I need to learn in anatomy because this is where I'm going to apply it in my practice. It makes them more involved in their learning. It gives them some meaning and it quickly catches their attention, and it enhances reinforcement of important areas or topics. And above all, retention of learning, which we saw a little earlier, how retrieval and how integration of memory happens and is required for developing the knowledge base. Now, the second question which we need to address is what should be integrated and when? This is a very straightforward answer. We need to integrate content knowledge and skill development in addition to integrating basic with clinical sciences and so on. So the first thing that comes often to our mind is when we talk about integration is horizontal and vertical integration, because those are the most often talked about terminologies. But what we should be thinking about is a little more broader way of looking at integration. They should integrate all the different experiences that they have in the classroom, by the bedside, different settings that they learn in, different sources that they learn from. All these experiences they should be able to put together in order to develop an idea of what medical practice is all about. So therefore, in undergraduate education, you have not only basic sciences and clinical sciences, the applied skills, the knowledge gained from prior experiences, their own a little bit of introspection, right? Which is what the attitude development is all about. And what we call communication, that is the social knowledge of how to interact with others, not only their peers, but also their colleagues from other disciplines, other healthcare professions, patients, relatives, and so on. So all these are required to be integrated in order to create the whole Indian medical graduate. So therefore, integration is implemented beyond the classroom. What we talk about horizontal and vertical integration is usually confined to the classroom. We call a clinician, we call a basic scientist, we ask them to discuss, and so that is in the classroom. But actually it happens elsewhere as well. It happens in the simulation center, it happens at the bedside, and the interprofessional settings where they work as a team, for example, in the community. So this is a very important question that we need to understand and answer, especially in this setting where you are talking about integrating palliative care into the undergraduate training. Because standing in a classroom and talking to them about palliative care may not have the same impact as taking them to a center or to a clinic where palliative care is being implemented, where they can actually experience, talk to patients, see what is being done there. Because it's not simply the knowledge, we also want them to develop an attitude towards palliative care. So how can we as teachers scaffold this integration? So one is the role of the learner, because as I said, it's happening in the mind of the learner. So the learner has to have effective learning skills. And then us as teachers, we have our major role in teaching and assessment, and also in designing the curriculum. So learning strategies, they have to have effective learning strategies where they can develop a knowledge base. I'm not going into that. As teachers, there are many strategies which have been described. We go into depth of the curriculum. We give enough time for instruction. Any connections that have to be made, any sort of making these linkages between prior and new knowledge, all this requires time. You cannot hurry it up, right? So you need to give enough instructional time for it to happen. And there is this concept of desirable difficulties. I will not go into those details. Those of you who are interested can look them up. It's just that you space out the curriculum, you space out the learning events, and also you have this, so this is the concept of desirable difficulties. So you give them challenges and you create difficulties. For example, you could give them an assignment, right, where they will have to find out answers for your question by maybe going into the field, maybe looking up literature, maybe talking to people. So they learn by actually doing, and you don't provide them with ready-made answers. So this is one way, and this enhances long-term retention and transfers. That is desirable difficulty. And we also help learners to learn effective learning techniques. And last is I have purposely put this thing at last because curriculum arrangement, like what you were talking about, the horizontal and vertical integration, is probably not just the only way. There's much, much more that we need to do as teachers to promote integration of learning. So, for example, when you take a class, as again, coming back to my own subject, as a surgeon, when I'm taking a class, I have to continuously help them to make the connections. Maybe ask them a few questions when I'm taking a bedside clinic, again, because I'm more inclined towards breast surgery. So if I take a class on a patient who is presenting with breast lump, or coming to the example of palliative care, if you're talking to them about a patient who requires end-of-life care, right? Constantly keep making connections between their physical condition and what is causing that physical condition, how you can explain that, and keep helping them to make connections among the concepts in different subjects. Also, in your assessment, it's very, very important, because you must have already heard of the saying that assessment drives learning. So unless we assess, it's also important because they need to retrieve their knowledge. So you design an assessment which will make them establish that connection amongst the concepts. So one example can be, you give MCQ items, let them select the answer. Ask them a question after the MCQ item to explain why they have made that choice. So that would be one of the ways in which then they have to give an explanation for why they chose a particular option. So this use of assessment to build integration is known as the testing effect or the retrieval practice effect. So retrieval practice depends on the cues you provide them. Cues here refer to the questions. So it all depends on, if your question tests only memory, then it will test only memory. But if your question is so designed that it tests whether they have made those connections in their memory, then the answer also will require for them to demonstrate that they have made those connections. So some of the ways in our previous session, when I took this particular topic, I had asked the participants to share what they do to promote integration. And some of them had listed these possibilities of starting with a real case scenario, emphasizing applied aspect, calling a teacher from the clinical side to come and talk about the applied aspects, personal experience, early clinical exposure, and so on. So there are many ways of promoting integration, and it all depends on you. So there is no prescribed way of doing it. There is no single right way of doing it. All we need to understand is we are helping them to make those connections between different aspects of their learning, and we can do it as we see it fit. Similarly, on assessment, they had talked about giving group tasks, asking a basic science question as part of a long answer question, using formative assessment methods, and so on. So finally, the curriculum arrangements, and the literature is replete with different ways of having integrated curriculum, right? So all these big diagrams and charts and all are available: horizontal, vertical, spiral, H-shaped to Z-shaped, and so on. You can have all this on paper, but unless you actually promote them to make their connections, all this will not be of, it's just remained on paper. This is the famous Hardin's ladder. Some of you might be familiar with it. These are very difficult terms, but ultimately it means that subjects which are taught in isolation, which happens most often traditionally in our that is the lowest level of the ladder. And finally, at the highest level, you have a transdisciplinary integration where there is no anatomy, physiology, medicine, surgery. It's there are no boundaries. There are no differentiation between different subjects. So that is finally that is labeled as an integrated curriculum. So curriculum strategies themselves cannot simply produce integration of learning. So what we need to see is that knowledge is built slowly, and you often revisit the learned information. So anatomists should ask questions from the applied aspects or the surgical importance of anatomy. Surgeons should ask questions from anatomy to help them to make those connections. So that has to go on. So there are in MBBS curriculum, we need to be trained. All of us should have our own responsibilities, developing integrated modules, design integrated assessment, and then have a design for how to deliver the curriculum. There are lots of challenges as you must be facing in your day-to-day practice. Basically, there is a lack of will, leadership support. The most common thing which comes up is we have only 2 faculty in our department. How can we go and participate in a surgery class or a medicine class? There are prefix mindsets. They say no, the clinician will not support me, or the basic scientist will not support me. So these are prefix mindsets. There is, I will lose my importance as a basic science teacher if I bring in the clinician too often, or if I keep talking about the clinical importance. Multiple teachers are required. It will cause confusion. Department will lose its identity. So these are some of the, I would almost say these are misconceptions, right? For example, this concept that multiple teachers are required. Actually, it isn't. If you take an undergraduate student or undergraduate curriculum, I have been through the MBBS training, and so have you. So you know what anatomy or what physiology they should be learning or they should know in order to understand surgery. So if I wanted to give a little more information on surgery or on anatomy, and if I wanted to ask them a few detailed questions in anatomy, I can talk to my colleague in anatomy and get some information from him or her and incorporate it in my class. I don't necessarily have to disturb my colleague in anatomy to come and spend an hour with me in my theory class talking about anatomy, which I can as well discuss, right? So it just requires communication between teachers of different disciplines to build the session. So I will end with a few take-home messages. Integration, primarily, we should understand, occurs in the mind of the learner. integration of learning is the desired outcome of any education. Knowledge integration is a process which begins automatically in childhood. Knowledge base is central to integration of learning. There is no escaping that. Memory integration is required for building the knowledge base, and that's what we should promote. And as teachers, to promote integration, we need to go into depths of certain curricular aspect, particularly conceptual understanding. We should give enough time for integration to happen and introduce desirable difficulties to promote their knowledge integration. Assessments are very important by providing an opportunity for practicing retrieval. Curricular arrangements themselves are not enough, and they do not result in integration of learning. Thank you very much.
Thank you all the participants for your patient listening. We are happy to take a few questions. It will be interesting to know or hear from you about the current practice in your institution about this integration. Like, how do you work with the other departments? For example, are you involved in AIDCOM teaching, or are you involved in taking sessions with the pharmacology department or with the anesthesia department? What is the current status now? It will be very interesting to know. Dr. Puneet has a question. Who is the sole integration with respect to palliation, whether it is anesthetist? I understand which department is primarily responsible for integration. I guess, Dr. Puneet, is that what you meant? Like, which is the primary department in terms of integration of
Yes, yes.
Okay.
Yes.
Sir, would you like to take the question? Or
Not an authoritative question, but many medical colleges, not all unfortunately, have medical education departments. And if there is a medical education department, without their involvement, trying to just going into a classroom and teaching a subject may not succeed in the long term. So that's one possibility. The other thing is, unfortunately, in most institutions, we are not in a position to discuss that question. The only person who is interested may be you. So this comes up very often, whether it should be public health, which is a very logical place to take the leadership. Anesthesiology as a subject takes a front seat often because pain management is essential to improve palliative care, and without that you cannot do much about a social or spiritual suffering. So very often anesthesiologists, historically in India particularly, not in every country, have taken a leadership. Then the most important thing, if you ask me, it's a personal opinion, the person with some interest in this matter should take the lead, get others together. That's a logical thing for me.
I think Dr. Sairu has put a message in the chat. That's what exactly I wanted to tell also. There is no primary department. The integration should be planned by all faculty trained in palliative care, irrespective of the department. Very, very correctly said, ma'am. Thank you so much. Yes, Dr. Puneet, like all the topics they have designed in such a way that it covers little bit in all the departments, starting from the foundation course to internship. That is literally spread over departments and over subjects also. So everyone has their own role to play when it comes to palliative care. That's why we ask for a very different representation from various departments in one medical college. I understand from your medical college also, so many specialities people are attending this program. So that is the strength, because now you have so many members trained across the years from first to final year. So that will be easy to integrate also. Thank you for that very, very important question, Dr. Puneet. Yeah, yes, I'm glad to see that they have 13 people attending from their institution, which is CDS IMER in Karnataka. They have undergone the foundation course and now undergoing the faculty development program. And that's the real essence of how we can integrate in a very good way. Dr. Ramadevi's comment on the chat. So the preclinical department taking the lead, anesthesia and the forensic department were called for end-of-life care DNR. I think this is a response to the question I asked, ma'am. Like, what is the current status of integration in your college? Thank you so much.
One thing to be cautious about now that this question has come up. What did we say? We practically said it can be any department if it's a person who takes the interest. But we are all human beings. I mean, no one here has wings flapping and behind you. We are not angels. We have our own limitations and problems. So unfortunately, especially in a new specialty, there is often much of territorial war. No, this is our task. You shouldn't come in. That kind of thing is totally to be expected. Why am I saying that? You come in with all good intentions. You do a lot of work. Then somebody comes in and says, you shouldn't be doing it. We should be doing it. I'll only say that we don't get discouraged by those things. I'm not going to say that you should pick up the sword and start fighting them, but quietly doing your work, not necessarily engaging in verbal battles, is rather important. Unfortunately, you will come across this. It's much too common, especially between territorial departments. Departmental egos can be much worse than individual egos. And that is a problem to be faced. So as far as possible, working together and working consistently forward is something to remember. Dr. Narayana says a palliative care physician can take the responsibility. But Dr. Narayana, out of the 703 medical colleges in the country, I don't know exactly, but only around 40 would have any palliative care. The 650 odd other medical colleges have no palliative care. This is an unfortunate reality. Yes, when there is a palliative care department, if that person is inclined to do this, that very obviously that has a huge role to play. But that person should also have enough time to interact with all these departments and take the movement forward. And unfortunately, in most institutions, palliative care physicians, of course not in everywhere, but in a majority, palliative care physicians are young and not with enough muscle in the hierarchy to take on heads of departments, etc. That's a possible limitation.
Thank you so much for the questions. Is there any other question? We have 1 more minute to wind up today's session. Hope there are no more questions. So the last 3 days, as I mentioned in the beginning, will be specifically group work. So I request all of you to get to know each other, other group members in your respective groups during the program today and tomorrow, because the small group discussions, you really need to give your inputs to your group so that we can come up with a good learning in the end. Thank you so much, all the participants. Tomorrow we'll be dealing a very interesting session and a very important topic, sharing the experience on teaching SHS and how to go ahead with teaching the serious health-related suffering to medical students. Thank you so much, all the participants. Thank you so much, sir, for staying back and taking the questions in the end. We'll see you all tomorrow for another session at 3 o'clock. Till then, bye.
Thank you everyone for joining in, and please, this is just a humble request that please do log in on time every day, because we know you all are tightly packed. We all know your busy schedules, how tightly packed you are, but please do treat this as important these coming 4 days, and please do pay your complete attention so that whatever we are doing, whatever you are taking efforts to gets fulfilled. Thank you everyone for joining in. See you tomorrow.